Okay, so now we're going to the last session of the evening, managing difficult cases of ALL. So we're going to go, we're going to do this in a case by case, like a patient presentation, because that's how I think it's helpful. Case one, a 65-year-old patient with a Philadelphia negative patient comes in who's MRD positive at the end of hyper-CVAD cycle 1B. What do we do in this situation? So the questions would come up is when in the treatment course should MRD be considered positive? So this patient is positive at the end of 1B. That is generally considered high risk for relapse, but when does one warrant a change in treatment strategy? And several trials have looked at this timing thing, and generally at the end of 3 months is considered when a shift has to take place, and we're going to go through that data. A definition of MRD positivities was already discussed in the previous talk, so I'm not going to go into too much detail about it. Like I said, the treatment has to be changed based on MRD positivity, so it's very, very important to actually measure this in patients with ALL. And the other question is, should these people be transplanted? So if someone comes in like this, you have an MRD positive disease and you do something to make it negative, what is the next step? The answer to that generally is once they are MRD negative, these patients are at high risk of relapse. So even though they're MRD negative, the standard protocol dictates that these patients be transplanted via an allogeneic transplant, but only after their MRD is negative, because if patients are transplanted directly with MRD positive disease, the rates of relapse is almost universal. So let's look at this patient. So this patient had 1B, so technically he could have another cycle to see if the MRD is still persistent at the end of the 3 months. And let's say at that point, this patient is now eligible for a change in treatment based on this study. The BLAST study looked at Philadelphia negative B-cell ALL who received at least 3 chemotherapy blocks of standard ALL treatment and was MRD positive more than 0.1%. In these patients, when blinatumomab was administered for up to 4 cycles, the rate of MRD negativity was very high. 82% of patients achieved an MRD negative rate. And this was seen in across all boards in terms of if the MRD was positive through first, second, or the third treatments. It didn't matter what the level of MRD was. The responses were seen across all levels of MRD, 67 to 78%. So based on this study, this patient should receive blinatumomab. The hyper-CVAD would stop, the patient be switched to blinatumomab, and once an MRD negative state is confirmed, to proceed with allogenic transplant. Usually the drug is tolerated. I won't go into too much detail about individual toxicities. We went through this last year in the same meeting, but you gotta watch out for fevers and some CRS, cytokine release syndrome events, but these are generally rare in situations with MRD positive disease because there's not a lot of volume of disease. So these symptoms are generally more likely seen in blinatumomab with lots of disease present, not in the MRD positive situation. Now let's say case 2. And there's a twist to it. So if you have a 55-year-old patient that comes with primary refractory Philadelphia negative B-cell ALL, and the second patient is a 25-year-old patient with relapsed B-cell ALL during maintenance treatment, so this is the first relapse. So we'll answer these 2 cases based on the review of literature. If you look at the Tower study, which is the first study, Philadelphia negative B-cell ALL who were either primary refractory, so our patient would fall into this category. These patients either got blinatumomab or randomized to any chemotherapy of choice. And if you look at the curves on the right, the blinatumomab, the median survival was higher with blinatumomab compared to chemotherapy, 7.7 versus 4 months. Obviously, this patient, if they do achieve a remission, should be transplanted as well. Because long-term cure rates are not yet, in patients with relapsed B-cell ALL, long-term cure rates without allogeneic transplant is not possible. The second patient, who's 25-year-old, would also could be eligible for the drug as well. Now, if you look at, and we haven't given the answer yet, but if you look at the effectiveness of blinatumomab across all groups, most of the time, most of these subgroups with regards to age, salvage treatment phase, and previous stem cell transplantation, blinatumomab was effective across all these subgroups. The only place where there is some perhaps borderline result, and this is subgroup analysis, but the bone marrow blast count over 50% is where blinatumomab versus chemotherapy shows more borderline results. It's not completely favors blinatumomab. There's also a slightly higher chance of having of significant CRS in people with a high volume burden. So this is what this trial showed in patients who have relapsed ALL. Now, what is the second drug that is approved in this situation? That's Inotuzumab ozogamicin, which is CD22 targeted chemotherapy. This trial, the Innovate trial, took patients with relapsed B-cell ALL, adult, relapsed after 1 or 2 previous induction cycles. So both of our patients would be falling into this category, and also included Philadelphia positive. Inotuzumab was given generally on a weekly schedule compared to chemotherapy, and Inotuzumab had a very high chance of going into CR. The CR rate in this study was about 80%, and with the increased overall survival compared to chemotherapy. So this patient would obviously be eligible for this drug as well. Now, if you look at the subgroup analysis within this study, and it is, we don't have to think too much about it, everything is on the right side, which means everything favors Inotuzumab, except for the 411 translocation, which our patient does not have. Interestingly, people with high blast count, or more than 50%, it also favored Inotuzumab, so one might argue that in this patient who has a frank relapse or primary refractory disease, the blast counts more than 50%, Inotuzumab, based on this subgroup analysis, may be a better drug in this situation. But you could also use blinatumomab as well. But data suggests that high burden disease is better with Inotuzumab. The third drug that is also, we call it drug, but it's really cellular therapy, are the CAR T-cells. There is, I won't go too much into detail about it, but this is the CAR T against CD19. The idea is that patient have a apheresis procedure with collection of peripheral T-cells. They're then transfected with CAR T-cells and then transferred back into the patient. There is a significant risk of cytokine release syndrome that needs to be monitored. Patients have to be hospitalized. This obviously is done in CAR T facilities only. Based on this concept, the CAR T cell that is tisagenlecell, one day I'll say this right. Anyways, this drug was given to patients with long-term CR rates, but it is approved only in patients up to 25 years of age and who are refractory or in second or more relapse. So our two patients that we talked about, the first one was primary refractory but 65 years old, would not be eligible for this based on the approval. There are obviously trials ongoing with a lot of these CAR T cells, but the approval would not favor this. And this is also approved only in second or more relapse. So our second patient, who is technically in the 25-year age group, would not directly be eligible at the moment, but if they get another treatment, like Inotuzumab or blinatumomab, and then proceed to have refractory disease, then they would be covered by this trial and be eligible. These are the long-term, what I call sort of, can't exactly say cure rate because these trials are still ongoing, but you can look at survival. At 6 months, it's about 67%. This is a line that some of these patients are still in continued follow-up, although patients are relapsing later as well, but this is obviously a very important, cellular therapy that has been approved. So now we talked about relapsed, Philadelphia negative B-cell ALL. What do we do about relapses with Philadelphia positive disease? So we have a 65-year-old patient here with Philadelphia positive ALL with a relapse. Question is, should we be checking ABL kinase mutation at the time of relapse to diagnose resistance mutations like T315I? The answer is yes. So a lot of the patients with Philadelphia positive ALL are treated with a combination of chemotherapy plus a TKI. So imatinib or dasatinib are generally used for this situation. And there have been reported late relapses on these regimens, and many of these relapses are happening because of the emergence of resistance clone in T315I, which is obviously sensitive to ponatinib. So it's important to order this at the time of relapse to understand if there is another TKI that could be used. There are ongoing trials, phase 2, that have looked at ponatinib in the frontline setting in order to avoid this sort of late emergence of resistance, and that is, some of the centers do use that, and we do use that in upfront setting as well. Now, if you have this patient, let's say if they have a resistant mutations or not, what are the options? Blinatumomab, Inotuzumab, switch to a different TKI? Do you have trials that could be for combinations of immunotherapies and TKI? So there are several options here. And there is a few data that are large, but lots of these are smaller phase 2 studies that have combined treatments. So obviously, if there is a T315I mutation and there is a molecular relapse only, then sometimes you could consider using ponatinib in that situation in order to bring down the clone. But let's look at some of the larger trials that have looked at that. The Alcantara study looked at Philadelphia positive ALL, adult, relapsed or refractory to at least one prior TKI therapy or intolerant to a second generation TKI. Patients received blinatumomab in this setting. And as you see, there were patients, and this is single agent blinatumomab, not with the TKI. And as you see, there have been responses to single agent blinatumomab with a CR rate of about 40%. So this is one option to do. There have been small trials looking at a combination of blinatumomab with TKI like ponatinib, and there are really small studies. It's like 11 patients kind of a thing, and have reported like 9 out of 11 CRs, but that's some of these trials are currently being looked at combining these agents in the relapsed setting. The second drug, the Inotuzumab, which we have discussed previously, this trial, the Innovate study, also looked at Philadelphia positive patients in the same fashion. And if you look at, again, the subgroup analysis, patients with Philadelphia positive disease also responded to the drug. So that is another option which is as valid as blinatumomab in this situation. And that could be part of the toolkit, I guess, for this patient. And again, the blast count would go into understanding, and obviously if the relapse is MRD only, then blinatumomab would be a better way to go. Now, the other frequently absolute lack of randomized data kind of patient that comes in is a typical older patient, a 79-year-old that comes with newly diagnosed ALL. So what do we do in this situation? What are the treatments available for older patients with ALL? And can we achieve long-term remissions without chemotherapy in this situation? So let's think about all the options. there are, in terms of standard sort of options, you could, in the old days, you could give just CVP, which is cytoxin, vincristine, prednisone, which can lead to remissions in some of these patients. Obviously, there have not been any long-term cure rates with these regimens. We sometimes use mini hyper-CVAD for these older patients who can tolerate some amount of chemotherapy. Mini hyper-CVAD is something that was developed by MD Anderson, where there's dose reductions in both A and B cycle. The A cycle is generally a dose reduced by 50%. It's not perfect. There's a whole regimen to it. And the B cycle also reduced significantly. And there have been remissions and some long-term some survival on these patients, but again, these are not obviously curative regimens. But in this era of newer agents and immunotherapies with elderly patients, what are the other options that could be available? There's a lot of clinical trials that are ongoing. There is one with mini hyper-CVAD with Inotuzumab. That is a trial that is enrolling. It is not standard of care, obviously. This is a clinical trial, getting a pretty good response rate of about 80% in these elderly patients with ALL. Obviously, we do not have long-term data on this. These are just newer trials. CVP with Inotuzumab is another upfront study that is enrolling. Some mild form of chemotherapy, sort of with blinatumomab, is another trial. TKIs in patients who are Philadelphia positive, plus blinatumomab. There have been regimens where you could use TKIs plus steroids and vincristine to achieve a remission, and then use blinatumomab to sort of clear MRD. Again, these are smaller trials. And in patients who are Philadelphia positive, the largest study to some extent, which has been published in older patients, is the EWAL regimen, where patients get chemotherapy, which is milder, in combination with dasatinib. Dasatinib is given at 140 milligrams along with vincristine and prednisone until CR is achieved, and once that's after generally weekly. It takes about 4 weeks, and once the CR is achieved, there is small chemotherapies with like cytarabine, small doses of PEG-asparaginase. These were all given in patients who are over 55 years old, so they're not your typical 79-year-old, and a 79-year-old should not get PEG-asparaginase, but just talking in general on this topic, this is also something that has been looked at with about 36% surviving at 3 years, and that's something we do consider in select patients who are older and Philadelphia positive and can handle a small dose of PEG-asparaginase. So in short, this patient has multiple options. With you're not going to have any big trials that can dictate it. So depending on availability, trial enrollment, you could consider some of these options, or go for a mini hyper-CVAD like situation, or just CVP. Now, one of the most frustrating parts of ALL management, I think, is relapsed T-cell ALL. We have all of these agents in B-cell ALL that are ongoing, but when you have a relapsed T-cell ALL, we really are lost in terms of good options that these patients can get cured from their relapse with. So there's only 2 approved drugs for relapsed T-cell ALL. There is lots of, similar to how there is a marker for CD19 in B-cell, there's nothing like that in T-cell, and there has been a lot of research that's ongoing, and genomics, and see if you could really look at certain subsets of T-cell ALL, and would there be a signature that would have small molecular inhibition, but we are nowhere close to any approval at the moment. But let's look at the 2 drugs that are approved in this situation. The first one is nelarabine, which is approved for T-cell ALL, and patients who had a relapsed disease did achieve CR with the drug with some long-term survival if transplanted. So if you look at the survival, overall survival after transplant, obviously this is hugging sort of the bottom, but there is, if patients do achieve a remission, they could be transplanted with nelarabine, so that's one choice. The problem with nelarabine is that the neurotoxicity seen with this drug is real, and it's seen very, very commonly in almost 70% of patients. This can take the form of tingling, numbness, small sensory neuropathy to severe motor neuropathy where the patients could stop walking, and there's no marker for who will get this or to what severity they will get that, and no real treatment for this. So mostly physical therapy is all we can do. There is some concern, obviously, that patients who do take nelarabine and then go on to get transplanted, and all the other regimens that do happen at that time, we have seen some patients with increased neurotoxicity even post-transplant. So this is something, it's an available agent, and we do not have any, so this is something we do use in patients with relapsed T-cell ALL who are younger and can handle chemotherapy, but it is not without toxicity, and patients have to be monitored very closely for developing signs of neurotoxicity, because there's frequently nothing you can do to stop it. The other drug that we sort of consider sometimes is liposomal vincristine. So if you have a very old patient who cannot handle nelarabine, liposomal vincristine has been tested in patients. It was mostly B-cell ALL that the trial looked at, but about 10 patients also had T-cell ALL, and the overall CR with liposomal vincristine was 20%, and in T-cell ALL it was also 20%. The duration of CR 23 months, time to CR 56 days. So survival was obviously 4.6 months, median survival, but it is something we could consider using if an older patient with T-cell ALL does want treatment. And with this, thank you.